Thank you very much, Dr. Young, and thank you, Dr. Cook, and the rest of our faculty for being here this morning. I just couldn't get away from this slide background. I'm so used to presenting this in the M&M format, and you'll have to excuse the fact that it still says health system here because I wasn't able to take that out either. But without any further preliminaries, we'll get started. So as Dr. Young pointed out this morning, this is a difficult therapeutic problem, especially in our, meaning the cardiothoracic, specifically thoracic population. And I realize that, but I also realize that this is something that will touch many surgical subspecialties and general surgery as well, and it's something that we need to be aware of and something that we need to always act quickly upon when it is diagnosed. So the primary objectives this morning is to, yes, unfortunately, but is important to discuss anatomy and some brief aspects of the physiology of the thoracic duct as relates to chylothorax in the setting of post-surgical patients particularly. And then we'll move on through a brief period of etiology and then discuss how we diagnose chylothorax, and then move on to treatment options. It all starts with the embryology, as Dr. Raff likes to say a lot. In this slide, I just want to point out briefly that the thoracic duct starts out as paired structures. So in the slide on the left, you can see that they're, as an embryo, all those lymphatic channels are mostly bilateral, with the cisterna chyli being that central sac in the middle under number 10 there. And then as things progress, things tend to lateralize as we know it in the most common orientation with the thoracic duct. It's going to be a little hard here, but starting out on the right side of the patient and then moving over towards the left side and then emptying into the junction of the subclavian and internal jugular vein. Now, unfortunately, well, I'll get to that in a second, but the thoracic duct is the largest lymphatic channel in the body. It starts down around T12 or at T12 with the cisterna chyli, which in some patients is variable as far as the size, which we'll get into a little later. And then, as I mentioned, it crosses from right to left at around T4 to T5 in most patients. It crosses up in the neck, which is important for us in thoracic surgery when we do cervical anastomosis for esophagectomy. And obviously other services such as ENT and spine in some cases may run into this structure during neck dissections. It crosses anterior to subclavian artery and then ends, as I mentioned, in the junction of the subclavian internal jugular vein. There is a bicuspid valve at the end of the thoracic duct to prevent blood reflux into the lymphatic system. It's about 45 centimeters long and up to about 5 millimeters wide, so not very big, and this gets important when we discuss some of the therapeutic options later on. This is just a brief slide, mainly to discuss the orientation of the thoracic duct as relates to the azygous vein, the esophagus, and then the aorta as well as the spine. This is more down towards the diaphragmatic level. So again, variant anatomy is quite common. This schematic is a little bit difficult to understand, but mainly it's just to highlight that there's many variations, and the frequency of the most common is in somewhere in the range of 60 to 70%, but it can be highly variable. The most common variant, which I think is important to know, is that the fact that a duplicate duct can be present, and it's most commonly found in the neck. And in fact, we had a patient who presented this type of variant anatomy in the recent past. And that would be more along this line here. So the main job of the thoracic duct is to transport dietary fat from the intestines into the circulation. And the substance, obviously, as we all know, is chyle. Anywhere from 2.4 to, I've even read, up to 4 liters is transported daily. So as you can imagine, any kind of disruption in the system would be, or could potentially be, very significant. It obviously has fat, protein, electrolytes, many vitamins, and then lymphatic elements to it, making it very significant in the sense that when you're losing a lot of this stuff into, say, a thoracic cavity, obviously, then the patient can easily become deranged in many ways, which I'll go through now. So accumulation of chyle in the thoracic cavity, obviously, chylothorax. With rapid loss of chyle, you can even develop hypovolemia because of the high volume in the system. Obviously, electrolyte derangement, as I mentioned, and then immunosuppression from the loss of the immunoglobulins and specifically T lymphocytes, making the patient prone to opportunistic infections. And then, just as an aside, chyle in itself has been described as being bacteriostatic, mostly due to its high acidity or fatty acid content. So, a little busy slide here, but at this point, at least in the reading, there's some variation to this, but thoracic surgery, according to the most recent reviews, has actually surpassed trauma as the most common cause of chylothorax in post-traumatic setting, traumatic being either iatrogenic or non-iatrogenic, as is depicted in this schematic on the right. The incidence after esophagectomy is described as somewhere between 1.5% to 4%. And then why this becomes so important, especially in our post-surgical population, is that the mortality is significant, especially in post-op patients. And this is a little bit dated information, but it's up to 50% if untreated mortality with a thoracic duct leak. And it decreases to 15% with treatment. So let's move on to diagnosis. I mean, I think maybe most people have actually have been able to participate in the diagnosis of this. But the main thing to realize is that, especially in post-surgical or traumatic cases, the clinical suspicion really needs to be a focus, because certainly there could be other reasons for high, say, chest tube output, but and it's not always the case that you see this kind of yellow, cloudy fluid that that you see in the chest tube, in those test tubes on the right. So, although color can help you make the diagnosis, other lab analysis such as centrifugation, which in chylothorax would not change, whereas in other, like pseudochylothorax, for instance, would you develop a meniscus and a change in the fluid type. But for our purposes, and at least here in the modern laboratory analysis, the presence of chylomicrons is specific to the diagnosis of chylothorax. Now, it's not always that the lab is able to process this. Oftentimes it's a send out, and so triglycerides is the way that we typically diagnose it. And in this paper, actually done in the 1980s, the study by Stotts et al., they came up with the criteria that if the pleural fluid triglyceride of about greater than 110 milligrams per deciliter was present, then there was a 1% chance of this being non-chylous. In other words, this was pointing to a chylous leak. However, if the triglyceride level was less than 50, it had a 5% chance of being chylous. So in other words, it was most likely not to be chylothorax. So there's a lot of management decisions that go into dealing with this, and this is just a sort of an overview before we get into the specifics. We'll get more into this in a minute, but basically low output and the determination or distinction between low output and high output chylous, say chest tube output, is an important distinction. There's a lot of data and a lot of different numbers thrown out there, but some say between or low output being less than 1 liter per day. Others saying greater than that 1 liter should be the cutoff. The most compelling numbers that I found during this presentation was that anything less than 10 milliliters per kilogram per day, so taking the patient's weight into consideration, may, and we'll get into this more, but may be amenable to non-operative management. And then high output was anything greater than 10 milliliters per kilogram per day. Patient condition comes into this. Obviously, if the patient is very hypovolemic, or you can tell that they're becoming septic, making you concerned about immunosuppressive pathology. All these things have to play into your management strategy. Now, I think it's important to differentiate, as we're specifically speaking mostly about traumatic causes of chylothorax in this setting, because we're surgeons, that the difference between non-traumatic and traumatic chylothorax is really two different entities and really should be managed and analyzed separately. Obviously, some of the medical causes include lymphoma and other causes of thoracic duct obstruction leading to perforation. And then the final point before we move on is that medical, surgical, and then interventional, which we'll talk about management, are often needed to be performed in a complementary fashion. So it's not really in an exclusive manner, but more how can we use all three of these types of management intervention strategies to our advantage. The traditional non-operative management is just to immediately make the patient NPO and start them on TPN. Obviously, you don't want them to become further nutrient deplete. So that has been and still is, I would say, in a lot of ways, the main first thing that you would do when you diagnose chylothorax. Obviously, you want to have good drainage of the collection wherever it is. And mainly it's going to be in the pleural space. We'll talk a little bit about octreotide and how it factors in. And then also there's a separate little slide on the nutrition strategies. And then the other goal as far as the non-operative management is to prevent further sepsis. So octreotide, as we know, is a somatostatin analog. It decreases splanchnic blood flow and intestinal motility. It inhibits many GI hormones. Theoretically, this may reduce chylous flow because of these effects. The effectiveness of this, as we all know from, or maybe has been discussed in the pancreatic setting, but the effectiveness is certainly debated still. There are retrospective data favoring use, and in fact, at this point, based on my look into this, that it really does make sense to start to use this, but you really need to sort of evaluate its effectiveness on a real-time basis, meaning, there may be other strategies that you're doing at the same time, such as NPO and other things, but it's okay to use this as long as you evaluate it on a daily basis, and then if you feel like it's not working, then to stop it, because cost does factor in. But according to multiple reviews, the efficacy should be reassessed at 48 hours and then continued only if there's a 50% decrease in the initial output. So I think the bottom line for octreotide use in the setting of chylothorax is that there is enough information to justify trying it, but that you need to quantify the response and then use it only if it seems to be helpful. Now, the other thing we were needing to talk about is the nutrition and dietary considerations with this. So there is a fair amount of data that exists, but nothing definitive as to the management of whether NPO status with TPN is better than, say, adding water, juice, fat-free protein, or even medium-chain fatty acids in the diet, which theoretically are not absorbed by the lacteals and so do not enter the thoracic duct system. Now, there's no hard evidence either way, but I think that my personal take on this is that NPO and TPN may be in the initial setting the safest, but at the same time there are drawbacks to using TPN as far as infection is concerned, and that it may be going forward worth testing whether or not letting the patient eat, because not eat but drink water or juice or fat-free nutrition may actually not hurt them in the long run, and may be actually okay in the sense that they have some oral intake and for their comfort, really. However, you don't, at this point, the jury is still out on that. This slide is busy, but it's really, this is all the published reports between 1981 and 2011 that outline the management of chylothorax as far as conservative management is concerned. So none of these patients or patient series underwent surgery. You can see that in this column here, these are all the non-traumatic and traumatic series, and then these are what they had done. So I highlighted pleurodesis here, and then lymphangiography here. There is a fair amount of variation, as you can see on the far right, with the success rate for a lot of these conservative management strategies, but I think it's important to highlight that in the right patients, some of these non-operative strategies can actually be successful, and we'll talk more about that in the setting of lymphangiography in a few minutes. So Dug et al. Reported that a decrease in chylus output to 10 milliliters per kilogram by the 5th day after leakage that was noted predicted success of non-operative management. So again, it's hard to quantify these into hard and fast terms, as these patients have to be evaluated daily, and the management strategies oftentimes have to be changed. But this is helpful to realize. And then between 25 and 50% of chylothorax reported to close spontaneously within 14 days. This is all comers, so this doesn't necessarily focus just on post-operative patients. So we have to take that also with a grain of salt. So the early operative treatment was described by R.S. Lamson, and he was the first to perform a thoracic duct ligation in 1948, and reported that after doing this repeatedly, he decreased mortality from 50% down to 15%. So how has that affected what we do for the treatment of this as far as surgery goes? Now, the timing of surgery is something that really is sometimes difficult to decide upon. So there's no obviously, as we pointed out, there's no definite non-operative interval agreement, but there is agreement on aggressive early non-operative approaches, such as NPO, or sorry, not NPO, but the making sure the patient doesn't become malnourished, and that that you quantify the output and make sure that they aren't becoming progressively ill in the setting of sepsis. Postponing surgery in the setting of progressive malnutrition is a bad thing to do. So if that's becoming the case, then you have to really step up the treatment decisions. And then the general consensus is that at a few days to 2 weeks, Somewhere between 5 days and 2 weeks is the usual time where these patients are intervened upon. Rigorous fluid and electrolyte balance is essential, and then, as I mentioned before, strict daily quantification of chylous output is important. So making the decision to move to operative treatment is important, and then there's several techniques that have been described. So this schematic looks a little bit almost impossible. I mean, when you're in there and you're seeing the thoracic, especially in a post-operative setting where the esophagus is now no longer in its usual setting in the posterior mediastinum, it not often will look like this. But thoracic duct identification and direct ligation has been used and as a management strategy. Also, supradiaphragmatic mass ligation of the thoracic duct, which I'll talk about more in a second. Anastomosis of the thoracic duct to the azygos vein, which you can see running just posteriorly. And then the use of fibrin glue intraoperatively. And then obliteration of the pleural space by achieving lung expansion. And occasionally this will require a pleurectomy and even a chemical pleurodesis. As far as mass ligation, it's helpful when you're not able to locate the site of the leak. Fibrosis and inflammation, as I mentioned, also inhibits ability to dissect the lymphatic duct and ligate it directly. There are two schools of thought as to whether a prophylactic ligation during esophagectomy is useful. There are many series that say it brings it down from around 4% leak rate to about 2%. And at this point, it's still oftentimes left up to surgeon preference and experience. The maneuver for this is to ligate all the soft tissue to the right of the aorta and to the left of the azygos vein and anterior to the vertebral column, as you can see in the slide. So in this 2016 study that was published out of Cologne, Germany, 906 patients between the years of 2005 and 2013 underwent transthoracic esophagectomy with prophylactic thoracic duct ligation. And 17 of those, which is about 2%, developed postoperative chylothorax despite the prophylactic thoracic duct ligation. Rethoracotomy and repeat ligation was successful in 14%, which was 93% of those patients. One had to have a second time redo ligation, and then 2 patients unfortunately died in the hospital due to the complication of chylothorax, most likely, and multi-organ dysfunction. The conclusions from this study were that routine thoracic duct ligation is recommended, and they also cited the evidence that the daily chest tube output and the experience that it was less or greater than 10 milliliters per kilogram was the threshold to reoperate and perform a thoracic duct ligation, and that this should be done, again, kind of vague terminology, but in the first few days, which what I could gather somewhere between 3 and 6 days. And conservative management was able to be performed only in 2 patients of those 906. And again, those were the patients whose chest tube output was less than the 10 milliliters per kilogram per day. And what this tells me is that this is unusual. I mean, it's unlikely that you'll have a situation where the output is that low and that they'll respond to conservative management. So moving on to interventional type technique, which actually has been around for quite some time, but in many ways, as I'll speak about now, has sort of fallen out of favor, and then has actually in the last few years kind of made a resurgence as far as a therapeutic intervention for the treatment of chylothorax, thoracic duct leak. So historically, the technique was as follows. You'd see that the interventionist would isolate or make an incision between the first web space down in the lower extremity between the first and second toe, find a dermal lymphatic, which was difficult. They often had to use loops, and it was difficult to do. cannulate it, inject a special iodinated oil contrast, and then use serial imaging to monitor progression up the lower extremity into the retroperitoneal system and then in coalescing in the abdomen before being able to even attempt intervention in the setting of coiling or embolization with glue. So this, as I said, is sort of cumbersome. It took some time. Our interventionalists here at UC Davis say that this is mainly a historic procedure. There's nobody actually doing it this way anymore because of the fact that it's time-consuming and all the things I mentioned. The technique that is being used now is what's called intranodal lymphangiography, which I don't know if you can appreciate it here, but you can see the lymph node here. And then what they'll do is bring a needle, as you see in the picture below, in under direct ultrasound guidance, avoid the vascular hilum, and then inject that same lipodiol contrast into the fatty portion of the lymph node. And again, they do this about 1 cc every 5 minutes, and usually it takes between 3 and 6 cc's, so 3 and 6 injections of for the contrast to actually reach the retroperitoneum and then coalesce in the single system in the cisterna chyli. They also increase their yield of this by performing the procedure bilaterally. At least in most series, they do it universally. So you can see the needle coming in here, injecting into the fatty portion of the lymph node. Then you see, this is the floral representation of it in that groin lymph node. And this is the bilateral view. And then this is as the contrast rises superiorly. And there's a few more pictures I'll show in a minute. But this is a 2016 review of lymphangiography for the thoracic duct and intervention for thoracic duct leak. The overall technical success is somewhere between 62 and 71%. And that again is catheterizing the thoracic duct. That's not being able to intervene. But it seems like the catheterization of the thoracic duct is the limiting factor in this, and I'll show you a video of that in just a second. They have more success with traumatic etiology. The clinical resolution of a thoracic duct leak with embolization is up to 90%, and that's providing that they can access and catheterize the thoracic duct in order to inject the coils and the glue. And then success was improved with the use of coils and glue, or just glue, but just using coils had a slightly less or a slightly lower success rate of 84 versus 91%. There are some complications related to this procedure. You can have a mild hypersensitivity reaction, most likely to either the contrast or the glue. One of the main sort of major, I guess you could say, complications was the fact that these patients were getting venous thromboembolism at a higher rate than, or they developed venous thromboembolism as a result of this procedure. And they attributed that to the fact that this procedure does take some time in the radiology suite with the patient having to be still. The oil dye can be inadvertently injected into the venous system, and this usually they say is actually not that significant and doesn't cause any adverse effects, but it can be embolized, as you might imagine, and can cause you can have a pulmonary emboli that actually they've had patients with a mild hemoptysis afterwards. And then as a result of the procedural sedation, aspiration can cause and can be an unfortunate event. This slide, or this box to the right is kind of interesting. Not to spend too much time on it, but it's interesting that diarrhea and abdominal swelling seemed to be something that came up. Again, this is in that 2016 review, looking at a lot of papers talking about the complications of this procedure. I don't know, they had to kind of quantify this into related and probably unrelated. I'm not sure how much of that is true, but it seems like the diarrhea at least is something that was noted and could be related to the fact that you have to put a finder needle transabdominally to reach the thoracic or the cisterna chyli during this procedure. So I just want to talk about two brief case reports that we have taken care of here at UC Davis that have had a combination of both operative and interventional treatment. There's this first one was a 22-year-old with a lot of medical problems, as you can see there, who presented with a cervical esophageal perforation and distal stricture. This had to be dilated and the cervical perforation managed locally. And then, unfortunately, during the course of her hospitalization, she developed a descending mediastinitis that required thoracotomy and drainage, and then developed a post-op chylothorax. So again, this is the, you can see the needle coming in. We talked to the interventional team about this because this patient's operative risk was high, and in fact we did go in to drain the mediastinal abscess, and there was so much inflammation and difficult dissection in her that we felt we were doing more harm than good, and to go back to manage this chylothorax we felt was going to be deleterious. So we talked to IR. They accessed the node. As you can see moving down here, they injected it, and then you can see the opacification of the left system. And as you can see, that this is one reason why they do bilateral, because oftentimes one side or the other has a greater success rate in the moving of the iodinated contrast dye up into the abdomen. They actually stopped here on the first day because the contrast seemed to stop here, and they felt like that giving it more time would be appropriate, so they actually came back the next day and noted that the contrast had indeed moved a little bit superior, but not that much, so they attempted to catheterize this duct directly. Now, this here was the cisterna chyli. They were unable to get into that, but just above that, and again, this is going to be hard to see, but really it's just to show the appreciation for how difficult it might be to access these vessels percutaneously with wires. But you can see that they're trying to get in there, and ultimately, by using a technique where they pull back fractionally on the finder needle, they were able to catheterize that duct and move the wire superiorly. So these are, unfortunately, they didn't have any live images of them deploying the coils or the glue, but this is after a coil injection. You can see all the coils up here. You want to get the coiled portion as superiorly as you can, obviously, to decrease the likelihood of leak downstream. And then they inject a glue behind the coils all the way down to the injection site. So just briefly, our second case, and just as a result, this patient had a drastic decline in their chylous output, and they resolved the chylothorax within 48 hours. A similar case, but this is a patient who underwent esophagectomy for megaesophagus as a result of end-stage achalasia, and that unfortunately, she also had a complication of chylothorax. We did intervene on her operatively within the first few days, repeated mass ligation of tissue between the aorta and spine, but unfortunately she had variant anatomy and this was unsuccessful. So again, we discussed this with interventional radiology. They did a similar technique. This was a little bit better anatomy. You can see that the access of this cisterna chyli was a little bit easier in this case, and they were able to do a similar intervention. Notably, this is a leak in her right neck. This is, again, as we discussed, a variation of thoracic duct anatomy, and so they were able to stop that. And then, kind of in conclusion, now there's a lot of the treatment of this, again, as you probably are aware after this presentation, is in flux. But I think this 2015 algorithm is important just to have as a background and as a sort of a schematic of where things might be going. A lot of the treatment does end in surgical management down here, but the interventional treatment is becoming more widespread. Not only just as a diagnostic tool, but as we have seen here at UC Davis as an interventional and correctional endeavor. So in summary, the chylothorax is very dangerous, especially in post-surgical and traumatic cases. Again, a high index of suspicion is required, and particularly in post-operative patients or in the traumatic setting. The diagnosis of triglycerides greater than 110 milligrams per deciliter in the presence of chylomicrons is essential. And then early intervention is important. Some sort of intervention as far as either make NPO, IV fluids, TPN, or maybe in the future some level of oral intake that avoids fat. And then early re-intervention for management of thoracic duct leak is recommended within the first few days if in the post-surgical setting. I think it's important also to say that all available management strategies, medical, surgical, interventional, should be considered and thought of as complementary in the management. And if the institution is able, would suggest an early discussion with the IR folks as far as the percutaneous management of this, because oftentimes, although surgical still is the gold standard in post-operative patients, it may change, and this can be a very important tool going forward in the management of this difficult problem. So with that, I'll entertain any questions. Thank you very much.
Really challenging problem, David. Thanks for reviewing it in such detail. And fascinating that one can actually cannulate that duct. It's like wet toilet paper, as they say, for trying to get a hold of.
Mm-hmm. Mm-hmm.
Yes, sir.
Is there any kind of adverse sequelae of ligating a thoracic duct prophylactically with some therapy as far as diarrhea, immunodeficiency, anything coming up?
No, because mainly, at least in the reading that I did, and that all the lymphatic channels will sort of find other ways and to reach the venous system, and really you're just trying to avoid a large leak related to the close proximity between the thoracic duct and the posterior mediastinum.
Dr. McVicker, I'm sure, remembers the days of transplant surgery from John Najarian and Tom Starzl when they would intentionally cannulate the thoracic duct to drain all the lymph out to make someone immunosuppressed. So the history of the thoracic duct is being an important agent in our immunological system is certainly well known. Got any comments on draining the thoracic duct or trying to cannulate it?
There's not very many people around that I think have been able to accomplish that. Us, our last interventional radiologist, was familiar with that.
What are you planning on doing in the future? Are you going to mass ligate the thoracic duct at the diaphragm when you do esophagectomies?
I would
You're
at
going
this
to.
point. At this point, I would. Yes. Yes.
So, with the point that Dr. Brown brought up, there's a resource here at UC Davis for this type of interventional procedure. If a person is at an institution with that type of resource, would you advocate shortening the conservative approach? So you said 5 to 7 days. Would you do like 48 hours and then refer to IR, as opposed to having that protein loss and immunosuppression for 5 to 7 days?
Yeah, thank you. Yeah, I think I would specifically because this can be used as a diagnostic and potentially therapeutic tool. And I think that right now that the drawbacks to doing it or the complications definitely do not outweigh or are not outweighed by the risks. So I think that if they're as good as maybe over 2/3 able to cannulate the thoracic duct, I think it's reasonable to go ahead and talk to them early and have them try it. Absolutely. Yes. Oh, sorry.
Anastomosis of the thoracic duct to the anoscus system has been described. I don't think you mentioned that. Any comments on that?
Actually, I did see that during the review. I really didn't see it as there wasn't a lot of data that I saw, and correct me if I'm wrong, but that really suggested that this was a good idea. It was listed as an option, and in fact I did see that and show that in a picture. But I certainly have not seen it. I don't know if any of our faculty have done that here, but I don't have any specific information regarding that.
Your illustration, when you talked about that, showed pledgets being used to ligate the duct. Is that the standard treatment recommended?
No, I mean that's not something that perhaps when you're doing a direct duct dissection and ligation potentially, but that's not how we do it.
Just put a hemo clip on it and
It's probably what I would do now. But when you're in mass ligating, I mean it's just a large needle in several different places in the supradiaphragmatic area. So.
You have a large chest tube output that looks serous. How do you make a diagnosis that it's chyle? What should we do when we have a chest tube in and it maybe looks a little bit funky, you're not sure? What's the best way to make the diagnosis?
Yeah, so the first thing is quantify the output. Second thing is send it immediately for triglycerides and chylomicrons. The triglyceride level will come back soon. Chylomicrons may, like I said, be a send out and take some time, but that's the gold standard. Laboratory diagnosis, but first thing I would do is you can just easily take some of that output right out of the Pleurovac and send it for triglyceride.
And any ingestible agents, cream, methylene blue, anything you should take in to look for chest tube drainage change?
I forgot to mention that intraoperatively we do use heavy cream about 20 to 30 minutes before we go looking for this if we have to reoperate in the setting of thoracic duct leak, but I actually have not used that at the bedside. So.
All right, last comments before we conclude for today? All right, great way to end, David. Thank you very much.
Thank you very much.